Welcome back to postoperative care. This is Tracy. We're going to finish up talking about postoperative care in our medical surgical clients. We're going to start with fluid, electrolyte, and acid-base balance. Things to consider and remember throughout the process. Our patient has been NPO. They've probably been NPO since midnight, and then they are NPO throughout the entire surgical period. They also have loss of fluid during the procedure. They can have loss of blood. We need to think about how many fluids they're given prior to surgery, during surgery, and after surgery. So fluid volume deficit or fluid volume overload may occur anytime. We want to be watching sodium, potassium, chloride, and calcium imbalances. With intake and output, that is part of the operative period and is typically reported by the circulating nurse who is taking care of the patient in the PACU. We want to include IV fluids, vomiting, urine, wound drainage. Do they have a specific drain-in, like a Jackson Pratt, an NG, Hemovax, those kinds of things. So we want to be looking at the total volume in as well as out, and the circulating nurse does report both the operating room and the PACU INOs so that we can follow those especially close during the first 24-hour period. With hydration, sometimes we can give ice chips and maybe sips of clear liquid in the PACU, but be looking at your patient for moisture of mucous membranes. Watch their skin turgor. Are they having any tenting? And when you're checking for tenting, make sure you're checking that over bony prominences. Again, watch those dressings, watch the drainage, and be able to identify INO. For IV fluids, typically what we see in the surgical, during the surgical period, pre-op, post-op, intra-op, we typically see isotonic solutions, so like lactated ringers or sodium chloride. That's usually what we see during the pre and intraoperative periods. Sometimes you'll see it change to D5-LR in PACU, but oftentimes you're just going to see lactated ringers being ran. Acid-base balance is going to be affected by our patient's respiratory status. We know that stress increases our metabolic needs, so we want to be watching for not only metabolic acid-base balance, but also respiratory acid-base balance. And then also consider the pain assessment. Pain assessment is started in the PACU and will continue on until the patient is discharged. For renal and urinary system, be watching for urinary retention. If your patients have Foley catheters, how much is in the bag, making sure our patient is having at least 30 ml of urinary output per hour. Oftentimes there will be parameters set that if they have 2 consecutive hours where they aren't meeting the 30 ml, you might have some additional orders, like maybe bolusing with IV fluids, or at least calling the surgeon to let them know and then receiving orders from there. So just make sure prior to calling your physicians you do have your quote-unquote ducks in a row so that you're able to talk to them and tell them what they need to know. Also consider how much vomiting, any diarrhea, those kinds of things. With your GI assessment, postoperative nausea and vomiting is very, very common. I don't know if I've really hardly ever taken care of a surgical patient that hasn't had some nausea and vomiting. So we want to make sure that we are administering antiemetics. So antiemetics that I would tell you that you should be aware of would be your Zofran, Reglan. Sometimes you see Phenergan used, Compazine, but make sure that we are getting our patients' nausea and vomiting under control. With the GI also, patients that are obese or have a history of having abdominal surgery, or if they're using opioids, oftentimes that will slow down intestinal peristalsis. So it's a good idea to get these patients up, get them moving, so that we can increase activity and try to get that motility restored to their colon. Be assessing bowel sounds as well. Typically when you hear bowel sounds, that means that peristalsis is returning. And so we want to make sure that our patient is passing flatus and having good bowel tones. So when you're charting body fluids, this is just a nice little acronym to remember about charting body fluids. So take a look at the color, the odor, amount, consistency, and how is the client tolerating it. So we want to make sure that when we are checking all of these fluids that our patient may be losing, what is our patient looking like, and what are these fluids looking like, and why. Skin assessment. Typically normal wound healing will occur without incidents. The clean surgical wound heals at the skin level in about 2 weeks. And then it will proceed from there. Patients that smoke or are older, obese, are diabetics that we talked about, patients that have used long-term steroid therapy, they definitely have delayed wound healing times. So it usually can take them longer for them to heal. Typically, the entire surgical incision, surgical wound will be healed within 6 months. Typically, normal wound healing will occur during the first few days. The incision tissue will begin to bind together. Oftentimes you will see staples, sutures, steri strips, those types of things. Your book does go into depth about fibrin and the epithelial cells creating that seal and collagen growth. I would say that it would be important to know the different types of drainage. So we talk about serous, serosanguinous, pus-like, clear. Want to be cognizant of the types of drainage. We also want to be watching that incision on a regular basis so that we can report any redness, increased warmth, swelling, tenderness, or pain, especially if it's not typical for the patient. With impaired wound healing, a couple of things that we need to consider are the wound dehiscence and wound evisceration. With dehiscence and evisceration, this is on page 291 of your Iggy book. This top part, what you will see is the, you can see that there's still a little bit of membranous tissue here. So with dehiscence, it's just partial separation of the wound. There is a partial or complete separation of those outer layers. So maybe the wound is just looking like it's splitting open. With evisceration, that's this bottom part where you can see intestines are coming out. And evisceration means that there's total separation of all wound layers. There's typically protrusion of internal organs. Problems are typically going to occur like this between the 5th and 7th days after surgery. So when you think about dehiscence and evisceration, what patients are going to be at most risk? With dehiscence or evisceration, it can be seen with following forceful coughing. Maybe the patient is vomiting, maybe they're straining to have a bowel movement or straining to get up out of bed. But the patient will typically, say they feel like something has gave way, or maybe my incision has split open. So when you're caring for such complications, you want to ensure that we have a damp, moist, sterile dressing to apply over that, and then definitely notifying your physician, your surgeon, so that they can take care of that. So here's just another pictorial image and differentiation between dehiscence and evisceration. If patients come back with NG tubes, it's basically utilized to decrease and drain the stomach. Oftentimes people that have continued, recurrent, and excessive nausea and vomiting, they will have NGs down just to help promote GI rest and give that tummy some time to rest and recover. You may see NG tubes used for enteral feedings. However, most of the time patients will probably be on total parental nutrition via a large bore IV or something of the such. We do want to make sure that we are assessing that drained material at least every 8 hours and then documenting the output. From intro to nursing, you did learn how to insert NG tubes. So here's just a couple of different types of NG tubes that you will probably be aware of or already know about, but these are something to consider as well. Some of the dressings and drains, these are on page 292 of your Iggy book. The bottom one right here is a Jackson Pratt or JP drain, and we'll talk about these drains in class and let you do some hands-on and get to looking at these types of things. These are used for surgeries where there's lots of irrigation, drainage. You will see these very often with mastectomy patients. The Hemovac, which is this one over here, letter D, the Hemovac is oftentimes used with joint replacements. You'll definitely see these are both closed system drainages. And the idea behind them is that it will collect the drainage. The Hemovac is larger than the Jackson Pratt. The Jackson Pratt, I think, holds about 60 cc's, where your Hemovac can be upward of 200 to 500 cc's. Letter A is just a Penrose drain, and then B is a T-tube. And what happens with those is they insert those directly into the incision site, and the drainage is allowed to escape that way, so there's no collection device. So when you're using those, you will have to be changing ABDs and dressings much more frequently. When we're using dressings or when we're using drains, we want to make sure that we are recording the output. Montgomery straps are used frequently when we think that dressing changes are going to occur. It helps reduce skin irritation from tape, and we also see these utilized because it helps sort of hold that incision together. So if you have a very obese patient, you can use these Montgomery straps, and it looks a lot like a corset, and basically what we do is tie that up and helps hold that incision suture line together. Other things, staples are very common to see, and this picture just shows an application of staples. The staple is just kind of positioned over that incision, and then they press the staple kind of into the skin, and then it just gives the skin a little bit of a bite and then helps hold that incision together. They're usually placed about 1/4 of an inch apart and usually come out between days 3 and 5 for abdominal incisions. Your joint replacements, hips, knees, those kinds of things, those staples tend to be in place for much longer periods of time, but it is the nurse's responsibility to remove those. With laboratory assessment post-operatively, we do need to continue to watch the electrolytes, as I just talked about. CBCs, we want to be watching white counts. We want to watch for hemoglobin, hematocrit, and we are going to discuss the normal values because it is expected that you will know those normal values. We'll be watching for left shifts. Maybe we're sending specimens down for culture and sensitivity. That would be the CNS that you see up on your screen. So those are going to be very common things for us to be managing in that post-op period. Also, arterial blood gases are going to be important to watch for acid-base balance. Watching urine and renal laboratory tests, we want to make sure that our patient is excreting and able to clear or filter the anesthetic agent out, making sure that they're not too dehydrated. Other things to consider, ECGs, which is the picture on the bottom of this page. We want to make sure that our patient is in that normal state or close to normal state as possible. So we do want to be watching those, and we will talk more about laboratory assessment when we meet. Potential for hypoxemia we've discussed earlier in the lecture. Its highest incidence occurs on the second postoperative day. So this is with hypoxemia, it's important to get our patients up, get them moving, initiating and continuing the breathing exercises. So even if your patient doesn't want to turn, cough, and deep breathe, it's part of our job to get them up, get them moving, and get those things happening. Potential for wound infection and delayed healing. We've discussed this. Make sure that you are cognizant of preventing infection, good hand washing, aseptic technique when we're changing those dressings, and then watching those drains for any airborne pathogens. Drug therapies, debridements of wounds, surgical management, just a couple of things to consider. And if you have questions over them, let me know. And this is a summation of the different types of drainage that come from surgical dressings, so I would be cognizant of what those represent. And I will continue on with the last few slides on the third and final presentation of the post-op period.